Good evening. I'd like to welcome you to our evening's lecture. My name is Courtney Campbell, and I'm the Hundair Professor in Religion and Culture, and our program, the Hundair Endowment, is sponsoring this evening's lecture, as well as many other activities throughout the spring that we hope that you'll take advantage of and come to. Our speaker this evening, Dr. Felicia Cohn, is currently the director, the Bioethics director for Kaiser Permanente in Orange County, and she's previously been the director of medical education at the University of California Irvine Medical Center, and is currently their ethics co-chair. We've had an interesting kind of long-term relationship, as we both attended the University of Virginia for graduate school and both had the same mentor for our programs. And I have the better intellectual legacy out of that. Felicia's become a heretic, as she describes it. But anyway, we're glad that you're here this evening. Dr. Cohn will go for about 45 or 50 minutes, and then we'll open it up for questions. Her topic tonight is Dying to Tell Stories of a Good Death. So please join me in welcoming Dr. Cohn.
Courtney just suggested I knock you dead, and that may be a little too apropos. All right, so I am here to talk to you about stories of dying. So I'm going to try to describe some difficult stories of care at the end of life, and then how healthcare professionals understand and respond to those stories, and then think about what we learn from those stories, the patient perspective. So I'm going to try to bring it all in. I've prepared 2 cases to discuss. I'll warn you now, I probably won't get through both of them, so I'll probably have to skip through several slides at the end. But if you want to stay and talk to me about other cases afterward, I'll be happy to do that.
Can you cut the lights a little?
Cut lights a little? I don't know how to do that, so I'll bring up the expert. Better? Okay, now I can't see you all. All right, so I'm going to start by telling you that I'm going to tell you some stories about patients, and that every patient tells us a story. We can learn from every patient. They say in research, every patient is an N of 1, meaning every patient is actually a research subject, because none of our studies apply to a particular individual. But in practice, in medical practice, every patient is a unique individual as well. What I'm really going to do is not only tell you a story about a patient, but a story about American culture and what dying means to us. And I will preface that by saying that in Oregon, you really are far ahead of the rest of the country. You've already started the conversation about end-of-life care. You've talked about it with assisted suicide. You've talked about it with the development of the pulse form. For the last 2 decades, you've started the conversation. But I'm betting that when it comes to the end of life, when you're actually heading to the hospital, that things aren't so very different here than anywhere else. So I'm going to start with a story. This was a patient. I'll call her Amy Lee, not her real name, not her real visual image. But she was 100 years old. And I chose this case purposely because it's an extreme. 100 years old. Would anyone be surprised if someone who was 100 years old were to die? Anyone? No. But her family was, and I'll tell you a little more about that. So she had actually been really healthy for that 100 years. She was the family matriarch. She had a history of hypertension, and that was really all that was wrong with her. So high blood pressure. But who doesn't have that? She was admitted to the hospital she had some diarrhea. She was dehydrated. Her kidneys were failing. She had what was called metabolic acidosis, meaning her systems were just out of whack. She was malnourished, and she just wasn't thriving. She'd lost 30 pounds over the last 8 months, although her family had kind of failed to notice that. She'd become short of breath once she got to the hospital and unresponsive, and she actually had what's called a PEA arrest, meaning her pulse stopped. She didn't have a heartbeat. She was revived, however, with CPR, which was absolutely amazing because she weighed about 80 pounds, and it looked like if you pounded on her chest, you'd break her. But she survived that and woke up. was actually able to speak a little bit, although not very coherently. She'd been intubated, so she was on a breathing machine, mechanical ventilator. She had blood pressure support, meaning we were giving her medications to keep her blood pressure up because it kept dropping down so low that she wasn't going to survive. And she was getting antibiotics because we thought she had what's called urosepsis, meaning just she was being overwhelmed by infection. Her prognosis, according to all of the doctors who had worked on her, from the emergency room to the step-down unit to the intensive care unit where she was finally admitted, all said she's probably not going to make it. She won't survive this hospitalization. So she had no advance directive, because that was the first question they called me, because there were lots of family members mailing about. She had no advance directive, so we had no guidance for the doctors to decide what to do with her. Now you'd think somewhere along that 100 years somebody would have said, you know, you're getting there. Probably looking at the end of life sooner rather than later. Any thoughts about that? But nobody ever had, or if they did, they didn't write it down. So 26 family members, 26, all milling around the ICU. Yes, 26. 5 children who, you know, as you can imagine, were in their 70s. 14 grandchildren, 7 nieces and nephews, all there. Very, very loved lady. Most of her family were healthcare professionals. So a very proud woman who had lots of doctors in her family. Lots of physicians, pharmacists, nurses, the whole gamut of healthcare professionals. Several family members were involved in decision making, and of course we're all fighting about it, because 26 people aren't going to agree on where to go for dinner, much less what to do with grandma. But most of the family was deferring to 2 of the grandsons. Interestingly, the one who they designated as the family spokesperson, not a healthcare professional. Businessman with 5 children of his own, who he'd left for the entire 2 weeks she was in the ICU with us. The other one was an intensive care physician, who, as it turned out, was a pediatric intensive care physician. We couldn't understand why he kept asking for all of these treatments that just weren't appropriate. Like, I actually wanted to call his healthcare facility and say, really, is he a doctor? Is he making it up? Because he was asking for things that were just bizarre for an adult patient. We learned he was a pediatric ICU doc, and then it made perfect sense. But the adult world and the pediatric world, totally different. But he's still demanding all these things because it just wasn't registering that a 100-year-old is different from a 100-month-old. So the family was in major disagreement, big conflict about the care plan, and all disagreed about what grandma would want. So the ethical questions, as I frame them, given the number of family members involved in the patient's care and decision-making, who is the appropriate decision-maker? Because when there's no one named, doctors actually get to choose. Who knows the patient best? Who seems to understand the patient's preferences the best? Who understands the patient's condition best? So they use this kind of criteria to decide. And given the difference in opinion regarding the patient's prognosis between the family and the healthcare providers, what course of treatment is medically and ethically indicated? But here's where we move from a case report to a story. Because I can frame all of those details, but that is not what's really interesting about Mrs. Lee. So, telling a story. We call this narrative medicine. Definition. What is narrative medicine? It's the ability to critically understand and be moved by the patient's story. So one of the founders of narrative medicine, Rita Sharon, that's how she defined it. Literature, if you are familiar with any stories of dying, most of it focuses on the patient's story, my experience with an illness. Little on student or practitioner stories, except when the doctor becomes a patient. And there's almost nothing on the physician's perspective about what it's like to actually take care of these people day in and day out. How does the doctor or the nurse deal with somebody who's dying? It's almost like we don't give them permission to tell these stories, permission to vent about them. And then we wonder why the divorce rates in the medical profession are so high. They take these issues home and complain to their spouse until the spouse says, that's enough. So written reflection offers stories that are useful educationally, so we can all learn from them in clinical practice and among the public. So, narrative categories. Now, we built these categories based on some work by an author named Arthur Frank. but we added to them because we wanted to try to capture the kind of stories being told in the healthcare setting. So these were the categories we came up with. I'll just go over them quickly. The first and probably the most common is called restitution, where conflict is resolved by appeal to a particular value or principle. And I'll tell you right now, the most common principle my medical students and my doctors now appeal to is respect for autonomy, which they often confuse with consumerism. So the patient said this is what he wants, that's what the patient gets, without sometimes stopping to think that's not really medically appropriate for the patient. Maybe we should talk about that a little more. But often I hear the patient said he wants to keep going, but didn't you tell me that the prognosis is poor regardless of what you do, so why are you going to keep going? Because that's what the patient wants. So that's the most common kind of story told. Second kind of story is chaos, where there really is no story. It's an anti-story. Things are just spiraling out of control around everyone involved, and often the healthcare professional ends up feeling demoralized. They just don't know what to do. Compromise, and this is the negative sense of compromise, meaning the healthcare provider had to compromise their values. They feel the choice is wrong, but they're doing it anyway. Journey, where the healthcare professional or the student struggles for resolution and is changed by the experience. So you'd think you'd want a lot of journey stories, but that would actually get kind of tiresome after a while. Witnessing, there's no immediate solution apparent, but the provider empathizes with the patient. So the healthcare professional kind of feels like they have to stand back and watch. You know, the durable power of attorney for the patient said this, I'm obligated to respect that decision, even though I think it's inappropriate. I'm just a witness to the processes going on in front of me. The next is resistance, where the provider chooses personal values regardless of professional ethics or pressures, meaning I don't care what the patient wants, what the family wants, I'm going to do what I think is right. And sometimes no conflict and no problem, which if there were too many of those, I'd probably be out of a job. But it is actually most of the time. There is no conflict and things proceed smoothly. But I don't get involved in those cases, so I can't tell you those stories. So how did I come up with these categories? Well, I worked with a team of people based on a class that I was teaching, and I'll tell you a little more about that class in a minute. We used papers submitted by medical students over a 3.5-year period. We had 299 patients that were complete that we used in all. So it was 3.5 successive cohorts of medical students. It was a retrospective descriptive study, and we did get IRB approval, or they said it was exempt. We didn't actually have to get approval, but they had to stamp it approved that way. So the class was called Reconciling Personal Values and Professional Obligations. So in the beginning I said we often don't give our medical students, our doctors, an opportunity to talk about the kinds of stories that they find themselves in, to share their experiences, to vent about them. So I developed a class where they could actually think about the things they valued, what was important to them, and the things they felt they were being asked to do in their new role as a medical student, as a physician, as a medical resident, whatever role they were in. And to then figure out where they felt there was conflict. Where am I being forced to do something that I otherwise wouldn't think was okay to do? So I asked them to write stories, to send me narratives in advance of the class that describe those situations, whatever they found. And I purposefully did this in the middle of their OB/GYN clerkship, so that there would be some obvious conflicts. Termination of pregnancy, contraception, genetic screening. There'd be really obvious books for those less creative students that couldn't come up with anything else. And I got a lot of really interesting stuff. And I learned a lot about why we tell stories. So why do patients tell stories? To get better, to orient themselves in their new world of illness, to make sense of their life, to see it as meaningful, to figure out what's symbolic about what's going on now, because we all want to find meaning in everything we go through. It can't just be purposeless. Movement, to show capacity for change or their ability to overcome circumstances. So yes, I'm dying, but I can still spend time with my grandchildren. Yes, I can no longer move my legs, but I can go on to play basketball out of my wheelchair. Whoops. Sorry about that. Moral action, to be heard, to find support in whatever situation they find themselves in. And then so I started thinking about, well, if these are the reasons that patients tell stories, that you can discern from all the literature that the patients have written about having had cancer and overcome it, or succumbing to ALS, or any other of the millions of terrible things that can happen to us. So why would healthcare professionals tell stories if we let them? To get better, to vent their frustrations with what they do all day at work, to fit themselves into the medical world, to understand how they fit in the story of other people's lives. Again, symbolic integrity, so they can make sense out of their role, find meaning in their role, beyond what society ascribes to it. To show capacity for change, to socialize or resist into this new world, and to show the power of person over circumstance, to overcome what is wrong in medicine. A lot of those compromise stories, a lot of the resistance stories. And moral action, to join with others, seek support, or to exercise their verse or personal moral agency. So lots of reasons for telling stories. So Mrs. Lee's story. So her family perspective. Everything they thought should be done to save the patient, if only the doctors would help her. So this is what we kept hearing from several family members, the most vocal among them, resisting that prognosis that their grandmother had been given. That she had lived a long and healthy life. She'd been functional and independent until this event. And it was true. There were photos of her from just months before where she had still prepared a meal for these 26, really more than that, including all the great-grandchildren. And she was presiding over these enormously long tables with the whole family present. I can't imagine cooking for 6 people, and she was cooking for probably 56 people. But she did it by herself. She couldn't drive anymore, but she did walk to the market. She was very functional at 100 years old. That inadequate treatment had led to her heart attack, that it was the doctor's fault she was as bad off as she was. There was no reason why she should have had a heart attack in the hospital. How could we have let that happen? So the doctors, they thought, had to fix their mistake, make her better, get her well again. They also felt guilty due to the limited time with the patient before the incident. Several of them admitted to me, if I'd just been there more. And even when I reminded them, well, you have 5 children of your own, how could you, and you live an hour away. So what would being there more look like? And then what would that mean to your family? And even the ones who lived closer by, you're a full-time physician. You work 80 hours a week. What would being there more have looked like for you? And even the retired ones, you're already 75 yourself. Being there more, what would that have looked like? But there was still a lot of guilt. She was considered the family matriarch. She was the person who brought the family together. So this was going to be a huge loss. It already was a loss for them. They weren't going to know what to do on Sundays anymore. So a big life change that none of them were prepared for. So my categories, I describe this as a resistance story. They were resisting the prognosis they'd been given. They were resisting the natural trajectory of life, the natural course that we all must die one day. So the resistance narrative, when one rejects conventional ethics in favor of personal views, sets a course of battle and rejection determined to stay true to their own moral precepts regardless of existing professional guidelines, especially when they're in a situation of greater power. So this family felt as if the doctors had to do what they said. After all, they were doctors themselves. They could tell us how to treat grandma. So the family of healthcare professionals understands dying but refuses to accept that this patient is dying because grandma wouldn't die. She couldn't do that to us. So a literary example, resistance, are you all familiar with Schindler's List? Do you remember that story? 1993, whoever saves one life saves the entire world. Oskar Schindler used Jews to start a factory in Poland during the war. He witnessed the horrors endured by the Jews and starts to save them. Very active resistance. And while it was toward a different end, I would say this family was just as resistant. They saw what they thought was wrong in the medical system, and they set out on a path to battle everything the doctors told them. Resistance narrative, this was an example from my students' class. Ultimately, one student wrote, I have accepted my decisions in this particular experience, although in the future I believe that I will opt for respectfully declining and asking to participate in another surgery. This was a student writing about being asked to participate in a termination of pregnancy. Turned out later that it wasn't actually a termination of pregnancy, it was a D&C after a miscarriage, but for the student it didn't matter. It still felt wrong. Another student wrote, if I had been her physician, I would have followed the wishes of the mother. This course would have put me at odds with the majority view of the residents and senior physicians and the currently recommended treatment guidelines for this situation. The arrogance of believing that a medical education gives one the right to make life-altering decisions for another competent person is unchanged, despite the modern, more liberal culture of medicine. So here is a student actually actively resisting medical culture. Saying, I don't care what all of my peers, what my supervisors, what all of the doctors around me said. I think we should have done what the patient wanted. The student had gotten to know this patient really well and felt like we weren't respecting what that patient wanted or needed. And so set out to resist what her supervisors wanted her to do with this patient. So this is back to Mrs. Lee's story. The physician perspectives, as you can imagine, were very different from what the family thought. Families asking for medically inappropriate treatment. That was what the first thing they said to me when they called and requested the ethics consult. They want us to do things we don't think we should be doing. They aren't going to benefit this patient. Do we have to do it? That's how the questions went. The patient did not get sick overnight, according to the physicians. The decline occurred over months, and they saw her decline as consistent with the natural dying process. So this family is just out of their minds, they've been blind, and they're not willing to admit grandma is dying. The family's making unreasonable demands for continued treatment. We're going well beyond the reasonable scope of care, well beyond the community standard. We shouldn't be doing all of this. Why are you doing it? I kept asking. Nobody really had an answer. Patient should be home on hospice so she can die peacefully in her home, surrounded by these 26 wonderful family members, instead of here in the hospital where they're just wreaking havoc. Too many families involved, and they're taking too much of our time. We have an ICU full of other patients, and we can't get to them because we have 26 people waiting to talk to us individually. And there's no consistent decision maker. We don't know who to ask. Who do we call about anything? If I want to change the antibiotics, who's going to give me consent? One family member may say no, another says yes, and who do I listen to? So from their perspective, this was a compromise narrative. It was, again, a negative story. They feel that they're conceding core personal values because of external pressures. That this family's pressuring them to treat this poor lady in ways they didn't think were medically appropriate. Their personal values were dispensed with. This is where the why. Why are you doing it if you don't think it's right? Expediency, desire not to cause trouble, self-protection, lack of confidence in their personal perspective. What I kept hearing is, well, they're all doctors. They'll know how to sue us. They'll know how to review the medical record and find anything we did wrong. And what if they're right? So they all felt that this was the best they could do under the circumstances, but they were also very disillusioned with the decision-making processes because there weren't any decision-making processes going on at the time. The literary example, this is one of my favorite stories from William Carlos Williams, 1938. The use of force. Then I grasped the child's head with my left hand and tried to get the tongue depressor between her teeth. She fought with clenched teeth desperately, but now I had also grown furious at a child. I tried to hold myself down, but I couldn't. I know how to expose a throat for inspection, and I did my best. Get me a smooth-handled spoon of some sort, I told the mother. We're going through with this. The child's mouth was already bleeding. Her tongue was cut, and she was screaming in wild, hysterical shrieks. Perhaps I should have desisted and come back in an hour or more. No doubt it would have been better. But the worst of it was that I too had got beyond reason. I could have torn the child apart in my own fury and enjoyed it. It was a pleasure to attack her. The damn little brat must be protected against her own idiocy, one says to oneself at such times. So compromise. He's compromised his values of the compassionate physician because he felt forced to by the pressure to take care of his child. So the physicians in Mrs. Lee's story felt pressure to take care of her in ways they didn't think were appropriate. They compromised their values. Student example of a compromised narrative. I feel that in the future there will be a middle-of-the-road type of course of action that I may take in order to satisfy my professional obligations and perform my duty as a physician, yet somewhat meet my personal values, especially with regards to the greatest good. To hear this student was really struggling with what the best thing to do for a patient was and felt like they weren't doing it. So revising the story. So here's where I come in on my white horse to save the day. If only it were that easy. If I could get a white horse, maybe it would help. So the context. Here's the story of our culture. Do y'all remember this guy, Cardinal Bernardine? And that might be hard to read. Chicago's Cardinal Joseph Bernardine. He died back in 1996. And when he found out he was dying, he thought, what a great opportunity. So here's that chance to make meaning out of any phase of life. I'm going to help teach people what dying means, what a valuable time it can be, how meaningful it can be. I'm going to help people understand how to die. But I thought it was really fascinating that the same week that this Newsweek appeared, sort of this time. So right next to each other on the newsstand, which would you pick?
They both talk about the Army sex scandal.
Yeah, well, it was that time. So you see these two on the newsstand. How many of you would pick this magazine? It's okay, you can admit it. I would. Despite what I do all day, I'd pick this one. Really? How can I be forever young? How can I get rid of these wrinkles and look like that until I die? I know, I've never looked like that either. But we can all dream. So as a colleague of mine, Janice Lynch Schuster, wrote, as a society we are inclined to believe that if we only live right, eat right, exercise, don't smoke, drink little, good health and nearly perpetual life will be ours. We envision an old age that mirrors those we see on TV or online, rocking a comedy like Betty White or skydiving like George H.W. Bush. So that's what we all believe. And that's what Mrs. Lee's family believed. She's done everything right. She's eaten well. She's taken care of herself. What do you mean she can't live forever? And I thought it was really fascinating in the last few weeks when Pope Benedict announced he was going to retire. And the world was stunned. So he said, before God, I have come to the certainty that my strengths, due to an advanced age, are no longer suited to an adequate exercise. I am simply a pilgrim beginning the last leg of his pilgrimage on this earth, Benedict said, as his well-wishers wiped tears from their eyes. So we couldn't believe that he would give up that position, that he would step down, that he might admit to the frailty of aging. His well-wishers, those in the crowd, screamed back at him, long live the Pope. And I couldn't help but wonder how he felt hearing that. Was he actually hoping for long life himself at that point? I suspect not. Because often once we get there, once we come to accept that we have started that last pilgrimage, we want it to come quickly and peacefully and painlessly. So the reality. Do you have anything that stops the aging process? Sure. What kind of disease would you like? Because unfortunately, that is the reality. So cancer might get us in our 40s or 50s. Heart disease, lung disease might get us in our 60s and 70s. Dementia and just physical frailty might get us in our 80s or 90s. Give or take a decade or two for any of those diagnoses. But that's the reality. And for the boomers, how many of you are in the boomer generation? Yeah. So by 2030, I think 1 in 5 of us are going to be 65 or older. So that's going to drastically change the way healthcare is delivered, our access and what's available. So we have a longer life expectancy over previous generations, but we have higher rates of chronic disease, more disability, and lower self-rated health than members of the previous generation at the same age. So we're living longer, but we're living sicker. Less likely to smoke cigarettes, and you'll have lower rates of emphysema and heart attack. But you'll have poor health status and increased rates of obesity, hypertension, high blood pressure, diabetes, and high cholesterol. So we're doing this to ourselves, but it's part of our culture. And it reminded me of a story from Jonathan Swift's Gulliver's Travels. Any Swift fans? A few of you had to read it for English class, maybe. Well, this was the story of the Struttlebugs. So it's one of the lesser-known stories. But for Gulliver, this was an ideal place. In this land, there were immortals. Do you remember this story? Is it ringing a bell for anyone? They had red dots. You could identify them because they had red dots on their foreheads. And he wrote, "Happy nation, where every child hath at least a chance for being immortal. Happy people, who enjoy so many living examples of ancient virtue and have masters ready to instruct them in the wisdom of all former ages. But happiest, beyond all comparison, are those excellent Struttlebugs, who, being born exempt from that universal calamity of human nature, death that is, have their minds free and disengaged, without the weight and depression of spirits caused by the continual apprehensions of death." So he thought, how amazing that would be to know you will live forever. All the things you could do. And Gulliver thought, if I were king in this land, I would be surrounded by these folks. I would surround myself by a council of the immortals. Think of what they could teach me. Think of how we could govern this land. Think of the lessons that we would learn. How history would not have to repeat itself. That is, until he met one. So the reality of aging. They were the most mortifying sight I ever beheld. And the women were more horrible than the men. Beside the usual deformities in extreme old age, they acquired an additional ghastliness in proportion to their number of years, which is not to be described. Not only did they become physically debilitated, but mentally as well. So why? Why do we persist in this pursuit of immortality? Persist in this culture of denying the natural end of life, the dying process? Well, for a lot of reasons. A lot of things have changed over the last 100 years. If you actually go back through history and think about what dying used to look like. We used to die in our mid-40s. So, I don't know about you, I'd be looking at my final years here. A lot of us would probably already be gone. And some of us probably wouldn't be wasting time in college figuring out what we're going to do in the next decade because we need to already be doing it. Now, we live usually at least until 78. It's actually gone down a little. It's closer to 77 now. But if you make it to 65, you're likely to live into your 80s. We die very differently than we used to. Used to be infection. There was no penicillin 100 years ago. So a simple infection could kill you. Accidents. We didn't have emergency medical services. And a lot of women died in childbirth. Now, we're more likely to die of cancer, heart disease, or strokes and dementia. So cancer, our heart, or our brain, something's going to go. There didn't used to be any disability because we couldn't treat the problems that led to chronic conditions. So the folks who would have been disabled died. Now, we can treat people so that they can live for a long time with many kinds of disabilities. Usually, on average, about 4 years, most of us will experience some decreased function that might be characterized as a disability. Financing, of course, has changed radically. Healthcare used to be a minor expense. You could barter a chicken for your healthcare. Try offering your doctor a chicken now. I dare you. See what he says. Now it's a huge public expense, personal and public. So prognostication. How do we know when people are dying? Why aren't we working on that to help people understand it better? So we actually do know a lot about the way people die, because we know what diseases we get and we know what they look like. So that first most common trajectory for the relatively younger, actually, is cancer. And with cancer, you can live for a really long time at a pretty high functional level. You're still going to work. You're still driving carpool. You're still taking your kids to baseball practice. And then one day, you get sicker. And at that point, people start recognizing that your disease is winning. That's when chemo's not going to help anymore. Radiation might only be for palliative, for pain control. And you're going to start declining, and pretty rapidly. On average, you're going to live another 6 to 8 weeks, typically speaking. And that might be when you're enrolled in hospice, although often I see it way down here in your final days. When you're there in the hospital ICU and the doctor's finally saying, there are mets everywhere. There's cancer in his bones, in his liver, in his brain. There's nothing more we can do. Let's look at hospice. And by then you often have days. So we know a lot about this trajectory, yet we don't really help people because we're so busy fighting the whole way. But we never prepare people along the way to help them. You know, to have the doctor say to you, look, you've got this terrible diagnosis. Here are the things we can do to try to fight it. Let's work together on that if you're up for it. In case it doesn't work, there are things I want you to start thinking about. I rarely hear that conversation because our medical students, our medical residents, our entire educational system is set up to teach our healthcare providers how to fight. And to not fight is a defeat. So the next trajectory, organ system failure. You get lung disease. You get heart disease. You live at a lower functional level, but you probably are still okay. You might need a little oxygen. You might have to have had a surgery. But you're still driving. You may still be working. You're probably a little older. You might be retired. And you have these exacerbations, times when it gets worse. And you go to the hospital. And we fix you up. And you go home. And you're at a little lower level than you were when you started, but you're still okay. And it happens again and again. And at some point, maybe your heart beats out of sync. Maybe you just get too short of breath. And you die. And when I get families saying to me, I can't believe Aunt Mary died. You know, they call me in and say, something must have gone wrong. I said, well, you know she's had heart disease for the last 4 years. And I see from her medical record she's been getting treatment and she's been on these medications. But yeah, I had lunch with her last week and she was fine. Well, tell me what fine means. Well, you know, she was on oxygen and she was taking 27 pills every morning, but she was fine. Because we never talk about what's not fine. Because we adapt. And we start getting used to this pattern. We get worse, fix you up, go home. Until you get worse and we can't fix you up. And you don't go home ever again. And that's really hard for us to accept. Because we've gotten used to doctor's rescuing us. Because medical technology is that good. Sometimes It's even worse. We can't fix you up, but you don't die, and you stay down here, unconscious. And we put a hole in your neck so we can connect you to a breathing machine, and we put a hole in your stomach so we can continue feeding you, and we send you off to a nursing home, and they take care of your skin, and they turn you several times a day and make sure you don't get bed sores, and you can live like that for a long time, never waking up. And we have that luxury in this society. If we value life as precious, we can do that. We can maintain life. But we have to think really long and hard about whether we want to count that as life. And this is a societal question. We have the resources, but it's probably not sustainable. The next trajectory, and this is where Mrs. Lee was, dementia or frailty. So this is the gradual wearing out of the mind or body, sometimes both, usually one or the other. And you're living at a much lower functional level, but you're still doing okay. Like Mrs. Lee, she could still walk to the grocery store, she could still prepare dinner. Her grandson told me she lost her house keys much less often than he did. Her mind was very sharp, but her body was wearing out, because we're just not meant to last forever. And you can putter along, probably with lots of healthcare interventions, blood pressure medications, maybe vitamins. If you look at some of these folks' calendars, month to month, there are weekly, bi-weekly visits to different doctors. All propping them up, keeping them going at a level that's acceptable to them until they finally just wear out. These patients, you almost never find in a hospice program because nobody is ever ready to say they're dying. So we've started asking, would you say this person has 6 months or left to live? Well, who knows? Would you be surprised if this person were to die in the next 6 months, next year? Oh no, she could die tomorrow. So would you consider hospice? Oh no, because she could live for a year or two. We don't know. We never end up in hospice. So what these different trajectories do is trick us when it comes to prognosis. We always want to know. It's not always the first question. How much time does she have, Doc? How much time do I have? And the problem is that doctors really don't know. They can go based on the literature, but we never know if the statistics apply to you, to the individual. We can go based on experience. Patients like this that I've had in the past generally don't live much longer than a few weeks, a few months, whatever their experience is. They usually don't know. So we actually did a study to look at this. So we looked at patients with this one, CHF. So these patients had an 80% chance, were given an 80% chance to live for another couple of months, just 1 week before they died. So this is days to death. So 1 week before their death, the doctor said, oh yeah, 80% chance to live at least another couple months. The day before death, they still had a 65% chance. So somebody tells me a 65% chance. You got a 65% chance it's going to rain. You going to carry an umbrella? No, not here because. Okay, coming from Southern California, you tell me there's a 65% chance of rain? I have 2 umbrellas. But so 65%, those aren't bad odds. Most people would assume they've got a little more time. Even for the cancer patient, where the trajectory is more well known, a week before death, 50-50. Day before death, we did a little better, about 20. So much worse odds. Although, give me a 20% chance in Vegas and I'm there. So you can do whatever you want with the statistics, but the reality is that we really don't know when someone's going to die. All we can do, say generally people with these kinds of conditions don't make it very long. So let's celebrate if you're one of those who does. But in the meantime, let's prepare in case you're not. But we don't. We don't have those conversations with our families. We don't say, look, if this happens to me, here's what I want, here's what I don't want. We don't write our wills. How many of you have a will? How many of you have an advance directive? That's actually a little higher than average. About 20% of the population in general. In the room, it was closer to 35. So this becomes the picture of death. So more than 80% of Americans say they don't want to look like this when they die. They don't want to be in the hospital. Don't want to be plugged in. And I think that playing God metaphor is really instructive. What I hear from the families all the time is, I can't turn off the ventilator. That would be playing God. I can't stop feeding her. That would be cruel. And it would be playing God. When I try to suggest that perhaps we already are playing God, that we've interfered with the natural course of things, which makes us more God-like than if we were to stop interfering, doesn't go over very well. And the reality is a lot of how we die ends up being contingent on where we live. So in some parts of the country, nearly 50% of people are in the hospital at the time of death rather than at home or in a nursing home or some other non-hospital setting. In these areas, the likelihood of being admitted to an intensive care unit during the last 6 months of life is also higher than average, as is the likelihood of being admitted to an intensive care unit during the hospitalization at the time of death. So you all see Field of Dreams. Remember that movie? Build it and he will come. We build hospitals and they come. We build hospitals and that's where we learn to take care of people. We don't build the infrastructure in our communities to take care of people outside the hospital. Now it's a little better around here because you don't have a hospital on every corner. Where I live, I could pretty much fall off the freeway into any of 4 hospitals. So unless I do something about it, I am doomed to die looking like that comic. Around here, actually driving up, I saw a lot of hospice cars. Lots of cars with hospice labels on them. So you've probably got a better infrastructure here. So people always ask me, or tell me they want more, without recognizing that sometimes more isn't better. I wasn't a very good student of economics, but I do remember this principle, the law of diminishing returns. At some point, your benefit levels off, despite the quantity. So we can keep throwing more and more medical technology at anyone, but at some point it's not going to help you anymore. And in fact, this might start going down. It's going to hurt you. And that's often where I come in and help the doctors. When we get to the point where the treatment produces greater harm than benefit, it's probably time to stop. But that's a really hard conversation to have with a patient or family. Especially hard if the patient is still awake. How do you tell someone who's lying in a hospital bed, able to communicate with you, that he's done? There's nothing more we can do to help cure him. What does help in greater quantities is palliative care, which is a really fascinating study result that doesn't get enough play. Studies prove that if we go into hospice, we actually live longer and better, particularly with cancer. So the metaphor, the analogy I always use is a car. When you're driving your car, puttering along at the 55 miles per hour speed limit, your gas mileage is going to be a lot better than if you're speeding along at 80. That tank of gas is going to last you a lot longer. So the human body is fueled like a car. And when we are pushing it with aggressive medical treatment, it's like we're speeding along at 80. When we slow it down and go to hospice, palliative care, symptom management, family support, it's like we've slowed down to 55. And our tank lasts longer. So Mrs. Lee's ending. We had 3 family meetings, and these were very long, grueling family meetings. Lots of doctors in a very large room to accommodate the 26 family members who insisted on being there. All the family, except for one grandson, finally came to accept that Grandma was dying. Some of them had said it to me from the beginning, but still persisted. They requested palliative care. They requested pastoral services. So our chaplains came in, and that really helped a lot. They changed the patient's code status to DNR because our nurses were terrified of having to do CPR on her again. They gathered the family at the hospital bedside, and she died peacefully, the way we all envisioned, surrounded by family. Except, of course, she was in a hospital room instead of at home. So ultimately, I would describe this story as a journey. The hero received a call. The doctors came to help. They encountered trials and tribulations, endured much suffering. This was weeks of angst. Accomplishes mission and returns to help others. It's an uplifting story, emphasizes the acquisition of wisdom. We did a very thorough debriefing on this case. I think the doctors learned a lot about communication skills, compassion, working with families, and addressing the reality of the patient's situation. Although we can overly romanticize these stories too. My favorite example, everyone's favorite, The Wizard of Oz. The Dorothy and Toto and the tornado, the family I would definitely describe here as a tornado. Threatened by evil demons and monsters, assisted by friends and guides, help from a local medical doctor and a specialist. We had our ICU docs as specialists, and the story came out okay in the end. A literary example, patient examines the doctor, from Boyard in 1992. I would hope that my doctor's authority and his charisma might help to protect me against soul loss, a sense of terrible emptiness, the feeling that your soul has abandoned your ailing body like rats deserting a sinking ship. I would like my doctor to understand that beneath my surface cheerfulness, I feel the panic inherent in creation and the suction of infinity. He should be able to imagine the aloneness of the critically ill. I want him to be my Virgil, leading me through my purgatory or inferno, pointing out the sights as we go. So doctor as guide, doctor as helper. And the doctors really did learn how to guide a family through this kind of situation. Student examples. I learned that there are a plethora of different ideas, different morals that can coexist together. Imagine that, different values all coming together. I've also learned to never turn a deaf ear to someone else's ideals. Experience is just as important as what can be found in a book. And hearing that from a medical student, quite a revelation. Patients are diverse, another student said. They will come in all different shapes and sizes, vastly different cultures, with a wide variety of beliefs and morals. And regardless of how difficult it is, we must treat each patient with the same compassion, empathy, and integrity as our favorite patient. It is important to realize that there are complex reasons behind any patient action. I know that patients will often make decisions that I wouldn't make because they have different priorities and beliefs. I now know not to become offended when a patient chooses something other than what I recommend. That was very instructive for the doctors in this case. The family was choosing something they didn't recommend, and they were angry. The most interesting thing, too, because this patient was from an Asian culture, the doctors didn't even want to bring it up, that the patient was dying. Because the stereotype is that in Asian cultures you don't discuss death. So it turned out, going back to the one adult child who was not there in the hospital, there was an advance directive. Patient had thought about this. She didn't want it. She checked that choice not to prolong life box. And had we known, the whole story would have been written differently. For the family and for the healthcare team. Probably a completely different narrative with probably a similar ending. But the getting there is important as what happens in the end. Unless you're the kind of person who always wants to jump to the last page of the book. So I'm going to skip through Aaron's case because we're running out of time. So the opportunities in revising difficult stories. Sometimes it just is a matter of listening. So I joked before that as the ethicist I wrote in on my white horse, but really all I did was listen. I pulled people together into a meeting and let them talk at each other, and I listened. And they felt heard, and they felt their feelings were validated, and they felt a connection to each other, the other family members, and to the healthcare professionals. When the healthcare professionals were able to explain what they were worried about, why they didn't want to keep treating the patient, it made a big difference. It wasn't just, from a family's perspective, doctor doesn't want to spend his time doing this anymore. It was the doctor really cares about her and is concerned he's hurting her. And now we understand that the physician's greatest obligation is to do no harm. And the doctors really were worried we're going to hurt her. And that will make her dying worse. We can address well-being, and we can discover the hidden messages that go on in a room. We can identify educational needs and incorporate new lessons that can change stories in the future. We can revision and reconstruct together. How do we want this story to end? Because we're all part of this narrative. We're not telling two different parallel stories. We need to come together to write the ending. And can we develop a better story? One that makes more sense, provides more meaning, makes us feel more hope and happiness. Since one of the reasons we tell stories is to find meaning in our lives. So the moral of the story, this is again from Gulliver's Travels. The reader will easily believe that from what I had heard and seen, my keen appetite for perpetuity of life was much abated. I grew heartily ashamed of the pleasing visions I had formed, and thought no tyrant could invent a death into which I would not run with pleasure from such a life. The king heard of all that had passed between me and my friends upon this occasion, and rallied me very pleasantly, wishing I could send a couple of the Struttlebrogues to my own country, to arm our people against the fear of death. But this, it seems, is forbidden by the fundamental laws of the kingdom, or else I should have been well content with the trouble and expense of transporting them. So while this is a satire, there's a really valuable lesson about accepting our mortality, making the most of our lives until we reach that point. The lessons from both Swift and Mrs. Lee's story is to think about your own story. A lot of things that have happened in the end-of-life movements are about control. Assisted suicide is not really about dying, about bringing about your own death, but about controlling the circumstances of your death, controlling what we otherwise cannot control. The hospice movement is also about controlling the circumstances of our death. And you have a choice to write your story the way you want it written. But you have to do it. You have to do the advanced care planning. And I will note that coming up this month, on April 16th, is National Healthcare Decisions Day. Did you know we actually had a whole day to celebrate advanced care planning? Yeah, who knew? Amazing. So that's a great day to bring it up, because I often get people saying to me, I can't talk to my family about this stuff. It's too morbid. Well, now you've got a day. You can say, guess what, guys? You know what today is? Well, let's talk about this. So then you need to talk to your doctor, because what really makes me sad is when I call these people's primary care physicians, when my patient's in the hospital, and none of them have any idea what their patient would want. I'm like, well, you were the one who diagnosed her lung disease or her Alzheimer's or anything else. You never talked about what you want? Never? Not even once? No, we were too busy talking about all the doctors she was going to need to go see now to help get better. Talk to your family. Talking to your family is the only way to avoid a Mrs. Lee situation, where you have 26 or even 3 loved ones fighting over what you would want. And they do fight, because when someone you love is in the ICU, facing what may be the end of their life, it brings out everything bad that ever happened in the family. All of those tensions, the fact that you stole my teddy bear when I was 5, it all comes out. And we fight. And we fight because we love you so much. And we can't let go, or we don't want you to suffer, or a little of both. And we feel guilty we haven't been there more. And it's always the long-lost relative in New York, the doctor in New York, who flies in and mucks everything up. So talk to your family, the whole family, so you don't get that estranged son coming in and deciding what mom would want. Finally, as Isaac Asimov, one of my favorite science fiction writers, wrote, "Life is pleasant, death is peaceful. It's the transition that's troublesome." So thank you for your attention, and I'm happy to take some questions if we have time.